final act of doing a theory. It's going to be a little Judith Butler, and I've got to admit it's probably not going to be pretty. I'm going to try not to dwell on it for too long because I'm trying to work out writing about it too, and intend to do some blog commenting on it too, but I've got to do a little entertainment here of undiagnosing gender from unbeing gender. So I've tried to do a few really close readings of it now, and I think I'm starting to wrap my head around it. I think I'm starting to also see this really great critiques that have been raised by folks like Keegan and Leland. And I'm trying now to bring it back to kind of what I've stated are my three key terms for this talk, which would be bodies, symbols, and restrooms. But we're gonna at least leave it to bodies and symbols for now. So back to the dilemma of Judith Butler's that I raised at the beginning here. This split that we have between looking at, atypical gender presentations and gender identities as problems, as these, red blips of problematic, in need of fixing genders on the radar, bodies that are in need of assimilation, bodies that are in need of help to fit in and feel better in society, and the other side of that being, societal barriers, societal problems, and stumbling blocks that, that handicap us all, that keep us all from really feeling like we can authentically be ourselves in spaces. And I think especially relevant for us because as academics we should realize that the classroom could maybe be one of the hardest places to authentically be yourself, to express yourself as queer or trans or as someone who enjoys and has kinky sex, as someone who really wants to learn more about love language, as a user of not only caffeine and wine, but marijuana. I think what always feels really important to me in talking about therapy and GID diagnosis is outing myself as someone who has done a lot of lying to at least one therapist. And I could probably talk for at least a good couple hours about the different lies that I told in order to pass as an acceptable candidate for GID and as an acceptable candidate for use of testosterone, and to a lesser extent as an acceptable candidate for chest surgery. It's got to tell us something about this system when another experienced voice in class has been not being able to obtain a therapist letter for surgery because of lack of a GID diagnosis. We've got to think there's something going on with the system that's just not sitting right. And this isn't about individual bad therapists or a secret underground network of evil pathologizing therapists, but it's about a system that while it really sets me up to fail, really ultimately fails me and fails us all. And here's why. It's all about bodies. So at the risk of sounding the doctor, I am going to think economic factors of insurance and paying for things like hormones and surgeries and therapists and blood tests and all of that crap. That I'll definitely tell you more about anytime you'd like. I'm going to take the risk of removing that for a little bit and talk about why GID diagnosis is really bad for us from the start. And when I say us, I mean us all. I don't just mean trans and gender non-conforming folk or folks who are diagnosed with GID as children who are, of course, 75% at least homosexuals. I mean us all. And here's why. This GID diagnosis holds as its ground the norm that one really needs to conform to a system of gender follows sex, follows sexuality, follows sex, follows gender, follows sexuality, desire. It fails us in stating that really these symbols are more appropriate for some bodies than others, and in fact, if into those symbols that are incorrect for your body, you've got to find a way to make you fit in better. If you're into those symbols that are incorrect for your body, you've got to give you the right body for those symbols. And, maybe insurance will cover that, and maybe it won't. But we're still basing this on the assumption that some folks need to be diagnosed as needing to change their body or as being able to change their body in a certain gendered way, whereas we know that, other folks with other bodies are definitely granted, at least access, maybe not financial access, but at least access with the lack of a therapist letter to the same surgeries. So, lacking a therapist letter in order to be able to gain access to chest surgery doesn't stop someone who's had an M gender marker on their birth certificate since, the day they were born and continues to identify with that gender marker. It may still cost that person lots of money. And I'm not saying I'm completely ruling that out as a factor in accessibility, but really saying that the system hinges upon an inequality of bodies, that it is still more acceptable for certain bodies to access certain things than others, and those other bodies, those abject bodies, need approval in order to be able to gain access, that they in fact need to be subjectified, need to be initiated, need to fit in to this symbolic realm of normativity. It insists that some bodies need that, and for other bodies, it's just normal. And so what I'm talking about really even isn't just about GID in the DSM. I think we could look, and I have looked at other diagnoses, and while I am still not claiming to know very much about psychology, I know I have a very limited knowledge of psychology and psychoanalysis that, yes, does include some Freud and does include Lacan, and is probably not anywhere near professional or would qualify me for being anywhere near getting a psychology bachelor's degree. But when it comes to gender studies and film studies and, of course, whatever extracurricular reading I can squeeze in, and so I feel good sort of challenging the notion that some people with some reading histories can have access to talking about the DSM, and some cannot, even if it, purports to talk about them and their bodies. I rebel against that. And sort of the whole notion that a book can pathologize any non-normative mind or body, and that is not to say that for some folks mental illness is not very real and something that they would want to, cure or fix for themselves in order to, in their view, better their life, make their body less painful or alter a state of mind. I'm not going to be willing to the reality of that, but I'm going to deny that there can be any authority on what is abnormal for a mind or body, when in fact we're talking about what is atypical, and I'm really going to grab onto that from the source which Butler is drawing it from, and say that atypical just feels to fit so much better, and maybe that's where my fake beef with the DSM is, that we're looking in terms of abnormal, and we're looking in terms of, helping this abnormal person, this abject person, this other body and or mind fit in to those structures better, or at least appear to fit into those structures better, instead of focusing on how we can really reform things at a structural level, and that means looking at things that I even think are good, so like law, and look at how we can affect things at that level in order to, to not need to ascribe abnormality in a negative sense, but in fact look at atypicality, and look at the ways in which the system fails folks. I see part of that failure in the DSM, so feel free to call me out on it.